Shantanu Mundal has joined in the name of Samadhita Mundal. Anyway, so we are all here. In another 1 minute, we'll start.
Could you please stop your screen sharing now?
So I think it is 7. So tell us when are we going to live? We're live on YouTube.
We are live now.
Okay. So after a long time, a very good evening to all of you. And this program is dedicated to all our budding researchers, the postgraduate trainees, without whom the science cannot progress. And all we know that no branch of science can progress without research. So research is the thing that takes the message of today towards tomorrow. So welcome to all of you. May I call upon Dr. Chandrima Paul, President of the Kolkata Association of Ophthalmologists, to deliver the welcome address. Madam, please.
Thank you very much, Dr. Surojit. A very warm welcome to each one of you here this evening. And this is the curtain raiser session of the annual Congress of the Kolkata Association of Ophthalmologists. At the outset, I'd like to thank Dr. Chandana Chakraborty. It's her brainchild, and she's really worked hard to put this entire session together. My best wishes to our budding ophthalmologists, as Surojit said, and the foundation of every state is really the education of its youth. And all the best to you this evening for this competitive PGT free paper session. My gratitude to all the moderators, conveners, and very specially to the distinguished jury for sparing time from your busy schedules to be with us here this evening. So a very warm welcome to each one of you, and over to you, Surojit, to start the program. Thank you very much.
Thank you, madam. Now, as Dr. Paul mentioned, that Dr. Chandana Chakraborty is the planner of this whole session. She has arranged for everything. So over to Dr. Chandana Ji. Please unmute. Please unmute.
Thanks to President Kolkata Association of Ophthalmologists and our Secretary, Dr. Surojit, for their wholehearted support to organize this PGT free paper competition, for which all the PGTs actually they are waiting very eagerly for this. Without much delay, I just want to introduce our moderator for this session, Dr. Anupama Das Biswas from Karshiang SD Hospital, and Dr. Brototi Rai from Regional Institute of Ophthalmology of Kolkata, who will continue this session. Please, Brototi and Anupama, start the session. The first speaker, just introduce the first speaker.
Yes, ma'am. Hello, can you hear me?
Yes, Brototi, continue.
Okay. A very good evening to all the esteemed judges, to all the organizers of this committee. I thank everyone deeply from my heart. I would like to inform everyone that there are total 15 participants. The instructions are as follows. There will be a 6-minute time duration for each presentation. At 5 minutes duration, I will let you know that you have 1 minute left. So try to wrap it up within 6 minutes, each of you. I will call your names in order, and you can start sharing your screen immediately. The first presentation is Dr. Trisha Ghosh. Please, Trisha Ghosh, start sharing your screen.
In between,
moderator, any direction for the judges?
in between, can we introduce our judges? Can we introduce our judges?
And any special instruction for the judges?
Each judges can ask 2 questions. We have our distinguished judges today, Dr. Arup Kumar Bose, Dr. Shantanu Mondol, and Dr. Alokesh Ganguly. I will request them to ask only 2 questions for each participants, so that we can continue the session and end the session in right time. So thank you, judges.
Our chairpersons are also here.
Our chairpersons, Dr. Amora De,
and Dr. Sanjay Thakur.
And Dr. Sanjay Thakur. I'm sorry that you chairpersons can't ask any questions. At the end of the session, we'll ask if you have got any feedback, but not in between the session.
Am I audible? So beginning with
yes.
So moving on, the first presentation, Dr. Trisha Ghosh. Can you hear me, Dr. Trisha Ghosh?
Yes, am I audible?
Yes, you are audible. Please share your screen. I will let you know when your 5 minutes is up so that you can wrap it up within 1 minute. You can start. We can see your screen.
Good evening, everybody. Myself, Dr. Trisha Ghosh. Today, I'm going to present on the topic, role of blood cells associated inflammatory indices in early screening of diabetic retinopathy. According to WHO, diabetic retinopathy accounts for 4.8% of the number of cases of blindness globally, and the total burden of diabetes mellitus in India is estimated to be around 79.4 million by the year 2030. A survey conducted by the Union Health Ministry in collaboration with AIIMS revealed that the prevalence of diabetic retinopathy in India is 16.9% in the year 2019. Diabetic retinopathy is a chronic metabolic disorder associated with long-term macro and microvascular complications involving eyes, nerves, and kidney. The angiogenic inflammatory and oxidative stress pathway play an important role in the pathophysiology of diabetic retinopathy. According to the inflammatory hypothesis, the leukocyte adhesion to the vascular endothelium directly increases the vascular permeability, leading to endothelial damage and due to release of free radicals, cytokines, and enzymes. Also, the platelet hyperactivity and increased thrombogenesis leads to capillary occlusion, leading to hypoxia and retinal ischemia. So the alteration of the blood-retinal barrier due to pericyte loss, microaneurysm formation, and capillary dilatation leads to accumulation of the fluid in the retinal layer, subsequently leading to diabetic macular edema. Since neutrophils mostly adhere in diabetic retinopathy, determination of neutrophil to lymphocyte ratio might reveal the enhanced microvascular inflammation in DR patients. On the other hand, platelet stickiness occurs in occluded blood vessels. Its size increases, releases more thromboxane A2 and beta thromboglobulin, leading to accelerated thrombosis. Therefore, the measurement of mean platelet volume and platelet to lymphocyte ratio might provide a diagnostic indicator of diabetic retinopathy. The aim is to study the role of inflammation in the pathogenesis of diabetic retinopathy. The objectives are to evaluate the relationship between diabetic retinopathy and platelet to lymphocyte ratio, neutrophil to lymphocyte ratio, and mean platelet volume, and to compare these values with non-diabetic retinopathy subjects. This is a cross-sectional study conducted over patients attending the ophthalmology OPD of a tertiary care hospital. Patients with definitive diagnosis of type 2 DM were screened for diabetic retinopathy and were divided into DR and non-DR group, and the blood samples obtained from these patients were analyzed. Patients with a family history of hypertension and diabetes, type 1 DM, patients with severe systemic disease, glaucoma, trauma, pregnancy, malignant tumors, severe cardiovascular and cerebrovascular diseases, liver and kidney dysfunction, blood disease, recent surgery, infection, and smokers were excluded from my study. Finally, we enrolled 30 patients in the DR group and 30 patients in the non-DR group. Out of 30 patients in the DR group, 17 were female and 13 were male. And in a non-DR group, 16 were female and 14 were male. And the age group of these patients varied from 50 to 60 years. Coming to the blood analysis data, in the DR group, the mean fasting blood glucose was 111.38 milligram per dl, whereas that of in a non-DR group, it was 107.93 milligram per dl. HbA1c in the DR group was 9.63%, whereas in the non-DR group, 9.4%. This column diagram shows that the mean neutrophil count in the DR group was higher than that of the non-DR group, whereas the mean lymphocyte count in the DR group was lower than that of the non-DR group. This line diagram shows that both the mean platelet volume and platelet count were higher in the DR group than a non-DR group. Finally, we calculated the neutrophil to lymphocyte ratio and platelet to lymphocyte ratio, and both these values were higher in the DR group than the non-DR group. A recent meta-analysis conducted by G et al. Indicated that the MPV values were significantly more in the DR group in comparison with healthy controls and in diabetic group without retinopathy. And another meta-analysis conducted by Liu et al. Indicated that the MPV and NLR values were more in patients with DR than in type 2 DM patients without DR. A study by Wu et al. Showed that neutrophil count in circulation was higher in patients with DR and was closely associated with DR grades, indicating the considerable role of neutrophil-mediated inflammation in the development and progression of DR. In another meta-analysis conducted by Luo et al. Showed as compared with type 2 DM patients without DR, the values of MPV, NLR and PLR were much higher in patients with DR. In our study, the association between mean platelet volume, neutrophil to lymphocyte ratio, platelet to lymphocyte ratio with that of diabetic retinopathy was investigated. As shown, DR group had significantly higher MPV, NLR, and PLR values as compared with the non-DR group. Thus, we can conclude that a routine blood examination would provide effective information to assess risk stratification of disease and early screening of diabetic retinopathy. These are my references. Thank you for your kind attention.
Thank you, Dr. Trisha. You completed well in time. I would like to ask the judges to start the questions.
Trisha, it has been an extremely good, innovative paper, but I have got two questions in mind. That if you can measure the neutrophil lymphocyte ratio to find out whether the patient might develop retinopathy or not, it's a very good option. But the thing is, how to differentiate that neutrophilia which has occurred as a result of diabetes is because of diabetes and not due to any other infective illness in the body?
So that's why, sir, I'm excluding all other criteria, like any infection in the body.
So can you exclude all infections in the body?
Like any recent history, we can exclude any recent history of infection or the time when the patient is visiting the OPD, and at the time when I'm collecting the blood sample, if he or she is having an infection history or not.
Okay. Okay. Other judges, please.
No, I don't have any question. Am I audible?
Yes,
Yes.
sir.
I don't have any question. It's perfect. For me, it's perfect. Thank you.
So another question can be asked.
One more question.
Yeah. So, Trisha, do you really think that it's going to help us clinically, and should we do it routinely in all our cases in a practice? To
Sir,
check whether the
after,
patient,
sir, by,
yes.
sir, by excluding all the criteria, we can do it regularly to find out. But it can't be extrapolated to.
What is the level of sensitivity and specificity of this particular investigation? Can you give us an idea that it's specific and sensitive to this percentage of patients? Okay, fine.
Thank you, Dr.
We have
Trisha.
Lokesh, Dr. Alokesh is there, no? If he has got any question, please.
Alokesh, you are not audible. Please check
Okay.
your microphone.
Then we go to the next speaker.
Thank you, Dr. Trisha. I would like to call upon the next speaker, Dr. Anujit Paul. to start sharing his screen. Dr. Anujit Paul.
Evening, is my screen visible?
Yeah, it is visible. You can start.
Good evening. At the very outset, I would like to thank the KAO for this opportunity. The topic for this evening is analysis of orbital blood flow patterns using color Doppler imaging in pseudo-exfoliation syndrome. Pseudo-exfoliation syndrome is characterized by an extracellular production and accumulation of fibrin particles, and its prevalence increases with age. In PXF syndrome, nearly all tissues of the orbital vasculature are affected, and there's accumulation of extracellular fibrin production in them. This has been collaborated and confirmed by several studies, as well as in the orbit and the orbital soft tissues. And therefore, there might be an impact of these accumulation of fibrin particles leading to the orbital vasculature impairment. Color Doppler imaging has widely been used in ophthalmology for ophthalmic diagnosis of routine ophthalmic and orbital disorders. And therefore, the accumulation of PXF material in the orbital vasculature along with the orbit as well as the orbital soft tissues may play a significant role in derangement of blood flow velocities, therefore predisposing a patient with PXF syndrome to pseudo-exfoliation glaucoma. With this knowledge in mind, we use color Doppler imaging to evaluate whether there is a relationship between the color Doppler indices between the different major arteries in patients diagnosed with pseudo-exfoliation syndrome. The arteries that were taken into account were the central retinal artery, the ophthalmic artery, and the short posterior ciliary artery. For color Doppler imaging indices, we chose peak systolic velocity, end diastolic velocity, resistive index, as well as a newer index that is pulsatility index, which has not been reported in literature before. Our study was a cross-sectional descriptive study conducted in a tertiary healthcare center over a period of 18 months, and all patients above the age of 50 years with bilateral pseudo-exfoliation syndrome that presented to our OPD were included into the study. If we received any patient who had received prior anti-glaucoma treatment, was a case of asthma or chronic obstructive pulmonary disease, any carotid occlusive disease, any history of stroke, or any medication that may influence the intraocular pressure or blood pressure, these patients were excluded from the study. Once we got our set patients, we took a detailed history and conducted a routine ophthalmic examination. Intraocular pressure was measured with Goldman applanation tonometry, and a gonioscopy was done to rule out any possibility of PXF glaucoma. During slit lamp examination, white dandruff-like material, which was seen on the pupillary edge, trabecular meshwork, or on the anterior lens capsule were used to clinically confirm pseudo-exfoliation syndrome. Once these patients were chosen, they were subjected to color Doppler imaging, and the machine chose was a Mindray DC8 ultrasound Doppler machine, which was analyzed by a skilled radiologist for every sitting. Coming to the results, the total number of patients chosen were 52 with age of 62.9 years with a standard deviation of plus minus 6.2. 63% were males with an N equal to 33, and 37% were females with an N equal to 19. So this is a graphical representation of the raw data that we received. As you can see, in the central retinal artery, there was a reduction of peak systolic as well as end diastolic velocity with a rise in resistive index. For ophthalmic arteries, similar findings were found with a decrease in peak systolic velocity and a rise in resistive index for the patients. And the short posterior ciliary artery also represented a similar picture, quite similar to the other two arteries. After that, we compared the blood flow velocities between both the eyes, and for peak systolic velocities, central retinal artery showed a statistically significant difference between the two eyes, whereas in short posterior ciliary artery and in ophthalmic artery, there was a statistically significant difference between the end diastolic velocity between both the eyes. Following which, we compared the arteries on the basis of blood flow velocities, and it was observed that on comparing the blood flow velocities, the significant difference between the three arteries was significant for PSV as well as EDV, but not for RI. So our study overall showed that the ocular blood flow patterns in patients with PXF syndrome show a fall in PSV and EDV in all three arteries with a rise in RI. The normative data chose to compare the study was done with the normative data for Indian population, which was conducted in 2021 itself. Our study also focused on calculation of the pulsatility index for each artery, and we calculated a mean value for each artery. However, since normative data is not present for this index, further analysis could not be done. The artery velocities were compared to student teachers, and there is a statistically significant difference between PSV and EDV between the three arteries of each eye, as I have mentioned, while there was no statistically significance between the resistive index between the arteries. So it can be concluded that there is a decrease in velocity in peak systolic and end-diastolic velocity in all three eyes of statistical significance in patients with pseudo-exfoliation syndrome. This was also collaborated with other studies, especially one conducted by Yüksel et al., which concluded the same findings. In a study by Cysts et al., it showed that individuals with progressive diseases have lower ocular blood flow rates, and a study by Tiwari et al. Focused on the hemodynamic changes and said that EDV was a more sensitive indicator for these changes. So in conclusion, orbital blood flow velocities are deranged in pseudo-exfoliation syndrome, and there is a statistically significant difference. Assessment of these parameters in pseudo-exfoliation syndrome can help us detect changes hemodynamically, which may not be evident clinically. These are my references, and thank you for your attention.
Thank you, Dr. Anujit Paul. That was a very nice presentation. Judges, would you like to ask your questions?
Now, what is the cause of glaucoma in pseudo-exfoliation syndrome? Is it the accumulation of the material at the angles, or it's the blood flow which is mainly responsible for?
Is the previous theory, it is multifactorial, sir. Initially, the accumulation of PXM material at the angle has been considered, but recent studies have shown that the orbital vasculature and it being more of a vasculopathy and the decrease in orbital blood flow to the optic disc may be a factor contributing to PXM glaucoma.
So what causes this lack of blood flow to the optic nerve in PXM?
So the same fibrillar material that we see on the anterior lens capsule and the pupillary margin and the trabecular meshwork is postulated to accumulate in the large arteries as well, therefore impeding blood flow. So the reason is that.
Does it have any systemic impact other than?
Generally, pseudo-exfoliation syndrome has also been described in the heart as well as the brain, but it does not have any known systemic impact reported in literature.
Okay, thank you. Thank you.
I have one question.
Nice presentation, yeah.
Very good presentation. I just want to ask that in case of atherosclerosis, there are changes, similar things happen in these eyes. So how can you differentiate between these atherosclerotic changes along with the TEX changes? Is that possible? If not, why? What is the pathogenesis of this? Is there any previous study or biopsy specimen related anything available in the?
So primarily atherosclerosis is associated with platelet fibrin accumulation and associated with dyslipidemia as well. So that is platelet fibrin accumulation due to increased viscosity and accumulation of the same in the tunica intima of large and small arteries. Whereas PXF syndrome is ideally an amyloid-like protein which has not been classified as anything related to any blood corpuscle particularly. So it is this amyloid-like protein which accumulates and it impedes the blood flow. So that is the main pathophysiological difference between the two.
Okay.
Thank you, Dr. Anujit Paul. I would like to call upon the next person. Dr. Surya Shekhar Das, can you hear me?
Yes, ma'am.
Please share your screen and start your presentation.
Pencil.
You may start your presentation. We can see your screen.
Ma'am, unable to full screen, ma'am. The presentation. Oh, yes, yes. Okay, ma'am. Good evening, ma'am. My topic is delay in cataract surgery in other eye, a mysterious paradox. Cataract is the commonest cause of preventable blindness in developing country. Multiple barriers surround cataract surgery in every country. But in developing country, particularly in India, lack of education, adherence to traditional healthcare approach, lack of family support, and difficulty in reaching eye care facility make the challenge even greater. The aims to identify the reason for delay the cataract surgery of a person who is pseudophakic in one eye and other eye has significant cataract. We select 200 patients aged above 55 years of any gender and who has one eye pseudophakia and other eye significant cataract for last 2 years who attend in our OPD. This is prospective questionnaire based single center study.
Hello.
Sir, can I audible?
You are audible, please continue.
Yes, you are audible.
Exclusion criteria, we have excluded the history of intraocular refractive surgery other than cataract surgery, media opacity other than cataract, bilateral cataract, and the mental disorder who are unwilling to study. Ethical committee clearance was taken. The financial disclosure was nil. We obtained the informed consent from then after ophthalmic examination done, and we give the pre-designed, pre-tested questionnaire in their own language and asked, and all answer from their individual patient we evaluate and statistically analyzed. The major reason for the delay in cataract surgery are social support from their family, and also they need permission from spouse in the absence of spouse from elder children who is not present home at the time. Another major reason of the fear of loss of work due to loss of duration absence after surgery. And some are pseudo-satisfied, did not feel necessary of the surgery. Unsatisfactory vision and coexisting systemic disease also makes the barrier. Also 12% feel that the winter is the best time for the cataract surgery. This table showing the different barrier according to age and gender. The younger age 65 years compared to the other 65 to 70 years, the undergoes second eye cataract surgery. Delaying are more in male than female due to fear of loss of work and income. In non-formal education group, they are facing some other problem. They have lack of information, communication, and they depend on their children who are working outside. Also, they have the sick grandchildren, and they believe the winter is the best. And in higher education group, they are facing another problem. They have the small family size and death and separation of the spouse, and the only children, they are not staying the parent, they are settled abroad. And working income, in working group, they feel the fear of loss of work income due to the long duration of absence after the cataract surgery. And unemployed people are dependent on their spouse or children, those are working outside. And in retired people, they are more reluctant, more neglected, and more pseudo-satisfied. They are unwilling to go to cataract surgery. And limitation, this questionnaire-based interview was taken only one time. Many a time, the answer was given by the family member. This is a major limitation in my study. And conclusion, increasing public awareness need to complication due to delay in cataract surgery. Lens-induced glaucoma like phacolytic, phacomorphic glaucoma also causes the blindness. Also need the regular counseling for cataract surgery. Nowadays, cataract surgery are the daycare surgery, no fear or no loss of work. And also all over the day, we perform the cataract surgery on not only the winter. A regular eye examination and increasing accessibility will provide a solution to the delay cataract surgery uptake. And thank you. This is my reference.
Thank you very much, Dr. Surya Shekhar Das. I would request you to on your video for the question session.
Thank you.
Kindly switch on your video.
Ma'am, on. On my videos.
I have no question.
I've got a question. If you are so
Yes.
concerned about the patient delaying for the second eye surgery, why don't you consider simultaneously both eye surgery in your hospital for the patients who might not turn up for the second eye surgery soon? What is the problem in your hospital doing so?
No, sir. Actually, with the counseling and we select in our OPD, those are unwilling patient and increase the cataract surgery and counseling them to those are unwilling the person and searching the cause why they are not attending the surgery.
Okay.
One more question, please. Any more questions for Dr.
Yeah,
Suresh?
am I audible?
Yes, sir, you are audible.
Yes, sir.
Yeah. Dr. Das, I just wanted to know that what was the status of the other eye and the vision in the other eye for these patients? An analysis of that as to the quality of vision enjoyed by the person in the
Yes.
other eye, how
Yes.
it affects the decision process of delaying surgery.
The major cause are not the vision, sir. Major cause the social support. They are alone, unable to come to the operation center hospital, or they are unable to known to the when and how the operation is occurring in the hospital. The communication gap, not only the vision, sir. Vision only 10 to 5% they are associated cause or systemic disease are unsatisfied. Maximum patient are satisfied. They are willing. Main cause the barrier of the social support. They are.
Okay, thank you.
Thank you very much, Dr. Suresh Das. I would like to call upon the Dr. Arpita Kunal. Can you hear me? Dr. Arpita.
If she is not available, please go to the next speaker.
Okay. The next presenter is Dr. Payal Khatua. Are you there, Dr. Payal? Dr. Payal? Yes, you are audible. Please start your presentation. You can start sharing your screen.
My screen is visible.
You're audible, but we cannot see your screen. Please share your screen.
Now it is visible?
No, it is not visible.
Yes.
Yeah, we can see it. You can start your slide share.
Yeah,
Start from the first slide.
yes,
Please go to your first slide.
and this is my first slide.
No, we can see your fifth slide actually. Do you have a good internet connection?
No connection problem. You go up, you take your cursor up.
Yes, we can see your first screen now. You can start speaking. Dr. Payal, can you hear me?
Yeah.
Yes.
Can I start now?
Yes, start.
I'm Dr. Payal Macular, and I'm going to present my presentation efficiency of intermittent diabetes CMP monthly versus yearly versus TAD protocol. Further new hospitalization is part of spectrum of disease which is age-related macular degeneration and causes abnormal growth of vessels from the choroidal vasculature towards the neurosensory retina in the dark membrane. Obesity is a fundamental tool for diagnosis and management of the patient of the CMP. HTOCT is popularly used for nowadays for examination of the patient. Quantified CMP appears on as hyperreflective areas contacting or in front of the artery. And the pathology depicts lobe-shaped appearance as a three-membrane formation. Retinal uvula always present to some extent in front of the active membrane. OCT has been proven as useful for monitoring the treatment response of anti-VEGF treatment, and it determine the requirement of the retreatment in case of TAD and PRN protocol. The objective of my study is to compare the safety of the patient.
Dr. Payal, your slides are not moving. Dr. Payal, your slides are not moving. You please, I don't know, your slides are not moving.
Can you hear Dr. Payal?
Yeah, I can hear. My computer showing it is slide objective slide.
But over here we are in the first slide only.
We cannot see any of your slides. Do you have a good connection?
I think you are sharing some other screen. You're not sharing the screen you are talking. You please share the screen on which your slides are there.
Yeah, we can see it now.
Yes, now it's okay.
Continue, please. We cannot see your slides anymore. Dr. Payal?
Can you take a minute? Can I start after the response?
Hello?
Can I restart after the next participant?
Yeah, you can restart. Would you like to present it later? Then we can move on. You can stop sharing. You can clear up your glitches and then join later. I will call you at the end. Kindly stop sharing. I would like to call upon the next presenter, Dr. Pratyay Chakraborty. Dr. Pratyay, can you hear me?
Hello, am I audible?
Yes, you're audible. Please.
I'm sharing my screen. Kindly let me know.
Yes.
Is my presentation visible? Is it visible?
Not yet. Hold on a bit.
I have shared my screen. I have switched it on. Is it visible?
Yeah, we can see it. You can start.
Thank you. I would like to thank everyone from Kolkata Academy of Ophthalmology for allowing me to present this paper. It is a paper which is a prospective study compared between two groups receiving intravitreal aflibercept and dexamethasone injections on patients with diabetic macular edema. I do not have any financial interest. Ethical committee clearance and written consent from patient and his or her relative has been taken. The most common cause of loss of vision in diabetic patients is diabetic macular edema, as we all know. Generally, there are various classifications. It may be diffuse or focal maculopathy. It may be center involving or not center involving. initially there is accumulation of fluid in the outer plexiform and the inner nuclear layers, whereas in the latest stages, the nerve fiber layer and the inner nuclear layers also tend to get involved. Here the aims and objectives of my study. The aim is to study the various aspects of the treatment of patients with diabetic macular edema treated with intravitreal injections of dexamethasone implant and aflibercept. The objectives are to compare the visual outcome, to compare the intraocular pressure changes, and to compare the central macular thickness with the help of OCT. This is a single center study conducted in a tertiary hospital in Kolkata. It is randomized, prospective, and comparative between two groups. The study duration is of 15 months. My sample size is 142 eyes. The entire procedure includes of complete ophthalmological examination. Visual acuity has been recorded with the help of logmark charts. Intraocular pressure has been documented with the help of Goldmann applanation tonometry, and anterior segment evaluation with slit lamp, along with posterior segment evaluation with slit lamp biomicroscopy and indirect ophthalmoscopy. And the only investigation which I have used is optical coherence tomography. The inclusion criteria are as follows. Any 18-year-old diabetic patient with diabetic macular edema who has clear ocular media, adequate pupillary dilatation, and is ready to give detailed information and consent with central macular thickness more than 300 microns in the central 1 millimeter macular subfield in his or her OCT. The patient must be treatment naive. So any treatment which he or she has received before, then it is excluded. Patient's intraocular pressure must be within normal limits. So any patient with more than 21 IOP using anti-glaucoma drugs or more than 23 IOP not using anti-glaucoma drops, maybe he or she is a glaucoma suspect, then it is excluded. Any active intraocular infection or inflammation is also excluded. Any kind of vitreomacular interface abnormalities appreciated with OCT has been excluded. FEK and anterior chamber IOL cases has been excluded. Any known hypersensitivity to fluorescein have been excluded, and known cases of ischemic heart disease, cerebrovascular accident, acute coronary syndrome have been excluded. I have two groups. 72 eyes have been allocated to dexamethasone, whereas 70 eyes have been allocated to aflibercept. The name of the dexamethasone group is Group D, and name of aflibercept group is Group A. I have given only one dexamethasone 0.7 milligram implant, whereas aflibercept injection 2 milligram has been given at an interval of months, 3 doses. The data was collected and analyzed with the help of Microsoft Excel and IBM SPSS software version 23. Independent students t-test and person's chi-square tests were performed. Here are the results. This is the age distribution bar diagram. It indicates that most patients belong to the 51 to 60 years group, and secondly 61 to 70 years group. This is the sex distribution bar graph. Comparison between dexamethasone and aflibercept. The light blue is dexamethasone and the darker one is aflibercept, indicating more male patients in case of dexamethasone and more comparable male and female cases in aflibercept. The ocular status, whether the patient is phakic or pseudophakic, phakic blue, pseudophakic red. In aflibercept, both are same, and in dexamethasone, I found more phakic patients. This is the best corrected visual acuity change throughout the treatment period. In case of dexamethasone group, Group D, the baseline before injection, the first month after 1 month of injection, second month after 2 months of injection, third month after 3 months of injection, and I have also followed the patient in the 6th month. This is the gradual improvement of best corrected visual acuity as it is evident. Similar findings in aflibercept group baseline, and we have 3 injections. So first month is 1 month after the first injection, second month is 1 month after the second injection, and third month is 1 month after the third injection. And I have also followed up the patient to 6 months. Comparison of the best corrected visual acuity between the two groups with the help of this histogram. The blue one indicates dexamethasone and aflibercept is indicated by the red line. Both of them are comparable, especially at the 3rd and 6th month. It's quite evident. The change in intraocular pressures are quite interesting. In case of dexamethasone, we had noticed a peak in the 2nd month, which gradually subsided or remained comparable after 3 to 6 months. In case of intraocular pressure in aflibercept, there was gradual rise in intraocular pressure with the increase in number of anti-VEGF injections. It is easily evident from the bar graph. Comparison of both the IOP charts for both the groups. The peak in the second month of dexamethasone is visible, and
Dr. Pratya, your
chronic
6 minutes is up. Please wrap up.
the change in central macular thickness with the help of bar diagram and also with histogram. The complications in patients with dexamethasone injection, most commonly subconjunctival hemorrhage associated with cataract and increased IOP. And in case of aflibercept, it's subconjunctival hemorrhage and ocular pain. Similar findings in Invictus study, comparison of anti-VEGF and dexamethasone injections, improvement of base corrected visual acuity at 6 months, and reduction in central macular thickness. This is an example before injection and after injection. This is dexamethasone. And VISTA and VVDMEs are recent trials which has also compared and got similar results in case of dexamethasone and aflibercept. And Peter Braca et al. Also demonstrated chronic sustained increase in intraocular pressure in case of anti-VEGF injection. My conclusion is efficacy of dexamethasone and aflibercept are comparable, and rise in IOP has been already noted and discussed. Compliance of patient is better in case of dexamethasone due to significantly lesser number of intravitreal injections. These are my references. Thank you everyone for your attention.
Thank you very much, Dr. Pratya. Please start sharing your screen for the question round.
Just a second.
I have one question.
Yes,
how do you randomize these patients? You haven't told us that how do you distribute these patients, which patient will get the Ozurdex or which patient will get the aflibercept?
Sir, it's single fold and blind. The patient does not know what he or she is getting, but the clinician, me or my guide, knows that what.
No, that's right.
Yes.
How do you decide that? Randomization should be done before in any study. That is a comparison between these two drugs, though. So you have to randomize first which patient will get that. That is a bias. If you think that the patient has a more CMT, central macular thickness, then you automatically choose steroid for that patient. That might be a bias.
Yes, sir.
So randomization should be there.
Okay.
Okay. Nice study. Thank you.
Thank you, sir.
Yeah, Dr. Chakraborty, am I audible?
Yes, sir.
Yeah. In one of your exclusion criteria, you put that allergy to fluorescein. So have you done FFA in all these cases? If not, then why that exclusion criteria is there?
Sir, actually, I have done fundus fluorescent angiogram in each of these cases, but I have not presented it because it does not have any significant correlation, or I'm not studying any parameters of FA in this study itself. But I have done it because in most of the cases of patients with diabetic retinopathy need a baseline FA done. Hence, that is also my exclusion criteria, so that I can work up for the patient entirely.
Yeah, but the cases of diabetic cases of macular edema, who have got a significant reduction in the dropout of blood vessels in fluorescein angiography, have you excluded all of them?
No, sir, I didn't take into account the findings of FA in my study. I only limited myself to BCVA, IOP, and CMT.
I think it should be included also.
Okay, sir.
That could be another bias. Yeah.
Okay, sir.
Thank you very much, Dr. Pratya. I would like to call the next speaker, Dr. Sanchari Sarkar. Please start sharing your screen. Dr. Sanchari. Can you hear me, Dr. Sanchari? Dr. Sanchari.
Yes, ma'am.
Yeah, please start sharing.
Yes.
Yes, we can see it. You may start.
Is my screen visible, ma'am?
Yes, yes.
Am I audible?
Yeah, you're audible.
Good evening, respected judges and fellow colleagues. This is Dr. Shantari Sarkar presenting before you efficacy of oral eplerenone in acute central serous chorioretinopathy. As we all know, central serous chorioretinopathy is a chorioretinal disorder characterized by serous detachment of neurosensory retina and retinal pigment epithelium with accumulation of fluid. Although the exact pathogenesis of CSCR is inconclusive, a role of increased levels of endogenous or exogenous corticosteroids have been strongly implicated. Darwich et al. Proposed role of overactivation of mineralocorticoid receptors in choroidal endothelium, leading to upregulation of the vasodilator potassium channels that leads to choroidal vasodilatation, fluid accumulation in the retina, and development of serous retinal detachment, triggering CSCR. Eplerenone is a selective aldosterone receptor antagonist and a steroidal anti-mineralocorticoid, which was first used for treatment of congestive cardiac failure. It is a potassium-sparing diuretic, and its use is related with hyperkalemia as an adverse effect. It was a randomized prospective comparative case series conducted in ophthalmology OPD of Midnapur Medical College and Hospital after taking ethical committee clearance. Patients more than 18 years of age diagnosed with acute CSCR presenting with the first episode were included for the study, while patients with chronic, recurrent or bilateral CSCR, presence of CNVM, any treatment for retinal disease and presence of any systemic condition for which eplerenone is contraindicated were excluded. All the patients who met the inclusion criteria were assigned to either the treatment group, which was treated with eplerenone 25 mg per day for 1 week and then 50 mg per day for next 3 weeks. Otherwise, they were given the placebo treatment of vitamin B complex. The follow-up period was for 1 month. Each patient underwent visual acuity assessment on Senner's chart along with serum potassium levels and imaging by SD-OCT at baseline and after 1 month. SD-OCT evaluation included calculation of central macular thickness and presence of any subretinal fluid. No patient presented with medication-related adverse effects throughout the course of our study, and we had no financial interests. A total of 162 eyes of 162 patients made the inclusion criteria and were included in the study with the following age and sex distribution, where we can see the mean age was around 35 years in males in group A and around 34 years in group B, while there was a clear-cut male preponderance in both the groups. At the follow-up visit after 1 month, in group A, that is the treatment group, we can see 56% of the patients showed complete SRF resolution, while only 22% of the patients achieved the same result in group B. After 1 month follow-up, the decrease in CMT was again higher in group A, that was around 309 micrometer, while it was around 207 micrometer in group B. Significant improvement in visual acuity was also noted in group A, around 6 lines, while it was around 3.63 lines in group B, which was on placebo therapy. Results also showed increased level of serum potassium of around 0.62% milligram percentage in group A after receiving eplerenone for 1 month compared to only minimal change in group B. Here we can see OCT of a patient from group A who presented with a vision of 6/6 and a central macular thickness of 610 micrometer. After receiving treatment for 1 month with eplerenone, the vision was restored back to normal 6/6 and there was complete resolution of SRF. While in this OCT from group B, the patient presented with almost a similar clinical picture with a vision of 6/24 and a central macular thickness of 411 micrometer. After treatment following the placebo therapy, although there was some improvement, but we did not achieve a complete restoration of vision or complete SRF resolution. Careful observation with regular follow-up is still accepted as the standard treatment modality in majority cases of acute CSR. Sun et al. Investigated the effects of spironolactone versus observation in patients with acute CSR and recorded complete SRF resolution in majority of treated patients with significant decrease in mean CMT and SRF and BCVA improvement in both groups. The results of our study revealed that oral eplerenone acting on the mineralocorticoid receptor pathway was more effective than observation in the treatment of acute CSCR. And we had the following findings. Decrease in central macular thickness at 1 month follow-up visit in the treatment group was significantly higher in comparison to control group. Vision improvement was significantly more in the treatment group at the end of 1 month as compared to the control group. Also, there was an increase in serum potassium levels noted in the treatment group, which is not clinically significant. We can conclude that oral eplerenone significantly decreases central macular thickness and improves visual acuity in patients with acute CSR. A higher and faster resolution of the disease is achieved. Close monitoring may be required while prescribing eplerenone in patients with high levels of serum potassium. This study shows that eplerenone can be an effective, non-invasive first-line treatment option for acute CSR. Our limitations were a small sample size and short duration of follow-up. These are my references. Thank you.
Thank you very much, Dr. Sanchari Sarkar. Please switch on your video for the question round.
Yes, ma'am.
Yes.
Can I ask some? Yeah.
Yes, sir.
So I've got two questions. Basically, 1 month follow-up for acute CSR is too short a follow-up.
Yes.
So since there is more than 80% chance that the patient will recover within a period of 1.5 months, 1 month might not be very conclusive. What's your opinion about it?
Yes, sir. I think you are correct that as we have known from literature that acute CSR generally resolves on its own by 4 to 6 weeks. But what we have tried to do is even for this 4 to 6 weeks, the patient actually there's a significant hampering of the quality of life, and especially because it affects the patients in middle to young age group. I think if we can intervene early, if we can introduce some intervention which can actually end this wait of 4 to 6 weeks, I think we can give them a better quality of life for that time. That is the reason why we decided to go for this intervention and see if we can actually give them a better vision, a better quality of life in a shorter period of time.
And there's another study which was by Shobha, I think Shiva Prasad from Morphils. It's a large study where they have used it mostly for chronic CSR, recurrent CSR, and not for acute CSR. And what has come out was that it's not helpful. It's as good as a placebo in that study.
True.
Yeah, Dr. Sarkar, I just wanted to ask you to
Yes,
mirror what Dr. Modul had asked the earlier presenter, that in deciding the groups, had you randomized?
Yes, sir. We followed alternate random sample.
Okay. The other thing is, as Dr. Bose has mentioned, you know, at 1 month, if you don't follow that patient for at least 6 months, and if you are suddenly stopping the drops, you have not clarified whether you have tapered the medications or not, or whatever. So what about the rebound phenomena which might happen?
Yes, sir. Our follow-up period was short. That was one of the limitations in our study. And although we have clinically followed up the patients, most of the patients, but if we could have extended the period of follow-up, obviously it would have been a much better study.
Thank you.
Thank you, Dr. Sanchari Sarkar. I would like to call upon Dr. Komal Jaiswal. Can you hear me? Dr. Komal?
Yes, ma'am. Ma'am, am I audible?
Yeah, you're audible. Please share your video, your screen. Yes, we can see your presentation. You may start.
Good evening, everyone. I would like to thank Kolkata Association of Ophthalmologists for allowing me to present my paper. My topic for today's presentation is role of UBM in guiding surgical strategies and intraoperative decision-making and modifications in patients undergoing triple procedure. My guide is Dr. Shreya Thitte ma'am, who is HOD and professor in Cysts, Indore. We all know that cataract, it is the second most common cause of blindness in the world. And when cataract coexists with corneal pathologies, visualizing the anterior segment becomes very difficult. In such cases, we plan the patient for triple, that is keratoplasty with cataract extraction and IOL implantation. Hence, proper preoperative assessment of the corneal diseases and associated ocular pathologies like synegia, adherent glaucoma, if there is any membrane, calcified capsule, and iridia, this is very important, and it can aid in optimal treatment and surgical planning and good visual outcomes. The ultrasound biomicroscopy, it plays a very important role in this, as it is the only modality that works on the ultrasound waves, and it helps to visualize the anterior segment structures through opaque media. It uses high frequency ultrasound transducer, usually performed with a 35 or 50 megahertz probe, In our institute, we did it with the 50 megahertz probe. This is very helpful in studying the position of the lens, iris, ciliary body, and the configuration of the anterior chamber angle, even in dense corneal opacities. And therefore, it helps the surgeon in prediction of the status of anterior segment, intraoperative complications, and assessment for finer visualization of the operative details and avoiding complications in surgery for better management and outcome. Material and method. Total 62 patients who underwent keratoplasty in our institute. They were screened pre-operatively by UBM, out of which 20 patients were considered for this study who were having cataract. After approval from the institutional ethical committee, we included patients with corneal lesions, either healed or non-infectious cases with no posterior segment involvement, and patients who gave consent for the study. We excluded patients with active infection and active disease or inflammation. A detailed history was recorded to complete ocular examination, visual acuity in both eyes, intraocular pressure, anterior segment details by slit lamp microscope, and B scan to visualize the posterior segment was performed. Keratometry readings of the other eye was taken to calculate IOL power for implantation, and ultrasound biomicroscopy was performed with a 35 megahertz transducer. All findings such as corneal depth, extent, edema, and thickness, along with the anterior chamber depth, position of angle, anterior and posterior synechia, iris details, and zonular status were taken into consideration by the operating surgeon pre-operatively before performing the triple procedure. This helped us in counseling the patient also. For example, if there is any patient who is aniridic, we can counsel the patient for the aniridic status. Similarly, if there is any posterior capsular rent, or if there is no posterior capsule, then we can counsel the patient for secondary IOL implantation. The results were as given below. Out of 62 patients who underwent large graft keratoplasty, 20 patients with cataract were taken, as I have already told. Out of these 20 cases, we divided these into 3 groups. One that were having only corneal opacity. 6 cases were belonging to this category. Then 7 cases belong to adherent leukoma category, and 7 in anterior staphyloma category. From the table here, we can see that while we compared for the size of graft, when we pre-operatively did the UBM, the size of graft was accurately predicted with the UBM, and similar findings were found intraoperatively by the surgeon. Similarly, for the anterior chamber entry also, we can see that we achieved the anterior chamber entry in the estimated clock hours as we found from the UBM findings, and in only one case it was under predicted due to iris incarceration. So here we can see that the anterior chamber entry was not found as per prediction only in one case of adherent leukoma. In this case, the predictability value was 71.42% and 85.71% respectively. And in case of corneal opacity, the prediction value for the anterior chamber entry was found to be 100% accurate. From this table, we can also see that in case of corneal opacity, 100% positive prediction value was obtained for the extent of synechia, and likewise a positive predictive value of 85.71% cases and 71.42% cases was found in adherent leukoma and anterior staphyloma. And it was under predicted only in one case of adherent leukoma and 2 cases of anterior staphyloma. In cases of extensive iris incarceration in the form of annular anterior synechia or membrane formation with meticulous dissection, iris loss can be prevented. This table shows us that the IOL position and zonular status was also predicted 100% accurately by UBM. Only one case of corneal opacity, we found dialysis, and dehiscence was seen only in one case of adherent leukoma, and rest all cases had intact zonules. So we can conclude that the ultrasound and several technologies they coexist for imaging the anterior segment details like optical coherence tomography, pentacam, and scanning slit lamp systems. But for visualizing the anterior segment in cases of media opacity, UBM is the best measure because it works on ultrasound waves rather than working on the light waves. And it is very helpful in all cases planned for penetrating keratoplasty, as the graft size, definition, depth prediction was made 100% accurate with no variability. And accordingly, we can plan other steps also in the surgery, like iridectomy or membranectomy with meticulous dissection, and iris loss can be prevented. Patient can be counseled preoperatively for aniridic status. Our study also demonstrated 100% accurate prediction for the lens status and integrity of zonules. In this table, we can see the conclusion of our study. We can see that in cases of corneal opacity, the extent of synechia was accurately predicted in 83.33% cases, and the posterior capsule status was also 83.33% accurately predicted, and rest all the parameters were predicted 100% accurately. Similarly, in cases of adherent leucoma also, the extent of synechia and anterior chamber entry, they were 85.71% accurately predicted, and the posterior capsule status was 71.42% accurately predicted. Rest all features were 100% accurately predicted. So the prediction value ranging from 71.42% to 100% is obtained for all these 9 parameters which we studied, where lowest prediction value was 71.42%, which is quite fair in number. And thus the UBM is best and reliable guide for pre-planning the surgical strategies and intraoperative modifications for best visual outcomes. These were my main references. Thank you so much.
Thank you, Dr. So that the questions can begin.
Yeah.
Please ask everyone to finish in time, because there will be marks deduction, discredit.
Yes, ma'am.
The participant can't
Dr.
finish.
Komal, please, can you hear me?
Yes, ma'am.
Should I ask?
Yes, sir.
Yeah. I have basically 2 questions. It's very relevant topic in our practice. But why have you used 35 megahertz probe and not 50 megahertz probe in most of your cases? Number 1. And okay. Just, please answer. Yeah.
Sir, actually, we had only 35 megahertz probe in our institute, so that's why our use was restricted to that only.
So can you tell me the difference between 35 and 50?
So with 50 megahertz probe, the details are more finer, they can be visualized, sir.
No, if you want to see the details of cornea more close to the surface,
Resolution is
more close to the
50
surface,
megahertz.
yeah, you'll have to change the megahertz. Secondly, the zonules are normally not very well seen with UBM. You said that you could predict 100% of the cases the state of the zonules with UBM. Can you actually see the zonules very well with UBM?
So actually not very well, but we can just have a rough idea whether the zonules are intact or not. Either we can for placing the IOL, that's why we need to scan for the zonules also. We need to comment upon the zonule also.
But none of your pictures that you had shown zonules, and you had said that you could predict 100% of your cases the integrity of the zonules. In none of the pictures that you have shown, I could see the zonules. How could you predict?
Sir, in this I have not taken any picture which showed the zonules, but we commented
zonules are not
upon
well seen in UBM. Zonules are not easily seen in UBM. Anyways,
yes,
okay, fine. Thank you.
Thank you, sir.
Dr. Roy, all the corneal transplantations in this case, were they optical grafts or were they therapeutic grafts?
So we included both type of cases, but most of the cases were therapeutic.
So if you are having a large button dissection, then the extent of the synechias wouldn't really matter in your clinical decision, because you're in any case going to include up to the limbus as far as possible.
Yes, sir.
Okay.
Yes, sir. We considered for the 8 to 9 mm graft patients. Most of the patients in this category were in which we did the 8 to 9 mm graft, sir.
Okay.
Thank you, Dr. Komal. I would like to reiterate to all the participants to please complete your presentations within 6 minutes, as marks are being deducted for extra time. The next presenter, Dr. Ishita Batra, please start sharing the screen. Dr. Ishita, can you hear me? Dr. Ishita?
Yes, ma'am.
Please start sharing your slides.
Yes, ma'am. Ma'am, just a second, ma'am. Ma'am, is it visible? Am I audible, ma'am?
You are audible, but your screen is not visible. Yeah, now it is visible. You can start.
Ma'am, is it visible? Am I
Yes.
audible? Am I audible? Am I audible? Am I audible?
Yes.
Background noise is coming outside of the voice.
Actually, a lot of feedbacks are coming. I think Dr. Ishita and Dr. Komal are, probably are in the same room. Is it? If it is, then please one of you turn the audio down. Yeah.
Ma'am, is it visible now?
Yes, yes,
Yeah,
yes.
fine.
Am I audible, ma'am?
Yes, yes.
A very good evening to everybody. I'm very thankful to the Kolkata Association of Ophthalmologists to giving me this opportunity for allowing me to present my paper here. I'll be presenting on mucormycosis. The topic is demystifying COVID-19 associated rhino-orbital cerebral mucormycosis. Dr. Sonam Verma, my assistant professor, guided me throughout this journey. I'll be starting. The introduction is the COVID-19 pandemic used steroids as a therapeutic agent in association with systemic diabetes and irrational use of antibiotics made the land fertile for fungal growth, as evidenced by the recent surge of mucormycosis, which entangled the sinuses, orbits, and the brain. The purpose of my study was to study the epidemiological factors.
We cannot see your slides, basically.
The
Please.
screen is not moving.
Ma'am, is it moving now?
No, 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 it is not moving. Go on to the next slide.
Ma'am, is
go on to the introduction. We can just see your first poster presentation. We can just see your first slide only.
Dr. Bututi, can you go to the next speaker?
Yes, ma'am. Dr. Ishita will come back to you again later. Please clear your glitches again. See to it. I would request the next speaker to come online, Dr. Megha. Dr. Megha Ajay Banka. Can you hear me? Dr. Megha, can you hear me?
Hello.
Yeah.
Hello.
Yeah.
Am I visible? Am I audible?
Yes, you are.
Yeah, 1 second. I'm sharing my screen. Okay. Is my screen visible?
Yes.
Hello?
Where is, we cannot see your presentation. You can see your screen, but on your presentation, yeah, now we can see it.
Okay, I'm audible and my first slide is visible, right? Hello?
Yes, right.
Your slide is visible.
Okay. A very good evening to all the esteemed judges, the chairperson, moderator, and my fellow colleagues. Today, I will be presenting a paper on analysis of inflammatory biomarkers in branch retinal vein occlusion, a case control study. So, branch retinal vein occlusion is 3 times more common than central retinal vein occlusion and second only to diabetic retinopathy as the most common retinal vascular cause of visual loss. A painless decrease in vision resulting in misty or distorted vision is the most common presentation for BRVO. The most serious consequence of the same is irreversible visual impairment and blindness. The main associated factors for BRVO are higher age, blood pressure, urea blood concentration, and a narrow chamber angle. The origin of BRVO includes both systemic factors such as hypertension and local anatomic factors such as arteriovenous process. It has been suggested that inflammatory markers may play a crucial role in the formation and development of this disease. The underlying mechanisms are regarding thrombosis and inflammatory processes that go with the process of this disease. Consequently, systemic diseases such as atherosclerosis, hypertension, diabetes mellitus, and hyperlipidemia are the major risk factors for BRVO. Now, the problem is that current treatment options do not address the underlying etiology of BRVO. The focus completely lies on treating the sequelae of the occluded venous branch, such as macular edema or vitreous hemorrhage or the tractional retinal detachment, which happens because of the neovascularization. In addition to relying on thorough history taking and a clinician's acumen to finding the associated findings, it is important that we have some objective parameters which can be associated strongly to BRVO, which would help us to establish a more concrete etiopathological basis and would act as an important diagnostic tool for the said condition. And there is very scarce data available on the association of such inflammatory biomarkers to BRVO, especially done on an Indian cohort. So the objective of my study was to find an association between the following hemogram and lipid profile parameters with the condition of branch retinal vein occlusion. Neutrophil is to lymphocyte ratio, platelet is to lymphocyte ratio, and monocyte is to HDL ratio. And to bring together these associations in one study specific to the Indian cohort. The study design was an institution-based retrospective case control study in the outpatient department and retina clinic at RIO Kolkata for a period of 10 months. And age and sex controlled 100 subjects from patients having BRVO and 100 patients with not having BRVO or any other ocular disease formed the study population. All patients eligible for the study were explained in detail about the study in a language comfortable to them with the help of a patient information sheet prepared in 3 different languages, and a consent form was signed by them. All demographic details were recorded, a thorough history was taken, and a clinical examination was performed. All previous medical records of the patients were reviewed. Pupils of both eyes of the patients were dilated using cycloplegic drops. Once dilated, a complete fundus examination was documented. The patient's blood sample drawn was analyzed for Bun and serum creatinine, complete hemogram lipid profile, and OCT and FFA and a fundus photograph was taken. And all the results that were obtained from these investigations were documented to make the following conclusions. It was a retrospective study and a statistical analysis plan wherein p-value less than 0.05 was considered for a chi-square test and unpaired student's t-test. So the following are the baseline characteristics for age and sex. Now, as you can see, the neutrophil, platelet, lymphocyte, monocyte, HDL was recorded, from which the NLR, PLR, and the MHR was calculated. And as you can see in the control, the values for NLR and PLR were, hello? Hello? Yeah.
Yeah.
The neutrophils to lymphocyte ratio value was higher in the BRVO patients as compared to the control population. So was the case for MHR. So the conclusion was it was expected that easily available and inexpensive inflammatory biomarkers such as neutrophils to lymphocyte ratio, platelet to lymphocyte ratio, and monocyte to HDL ratio would be found in higher levels in diagnosed patients of BRVO, which was the first of its kind study relevant to the Indian population. Proven as expected, we were able to link these parameters as pertinent biomarkers for BRVO, which help us make a more objective diagnosis with a stronger etiological basis for BRVO. Thank you.
Thank you, Dr. Megha. Judges, please on your video. Yeah. Judges, the questions.
Hello, Dr. Banka. Did you analyze the systemic diseases associated in those patients
Yes,
who had
sir.
BRVO?
Yes, sir. So we all are well aware of the fact that diabetes and hypertension and a lot of systemic diseases are known to have association with retinal vein occlusion in ocular conditions. So, sir, the study has a very strict exclusion criteria where we have not included patients who have diabetes or hypertension and have still developed BRVO, which is why we have a limited sample size as well. So we have tried to exclude as many possible known causes for inflammation which can be ruled out. Obviously, of course, it's not possible to rule out all the causes of inflammation, but how many ever which we can on basis of meticulous history taking and clinical examination.
So, in what sense do you believe that they should have a predictive value in the general population?
So in terms of the normal range, you mean, sir?
Yeah.
So the normal range. So this was, sir, done in case considering the p-value being less than 0.05. But so this was a very limited sample size of just 100 patients. So we cannot extrapolate it to a bigger sample yet. But so the normal range. So I cannot comment on that yet, sir.
And another thing is this, that all these laboratory values were computed, estimated from different laboratories.
No, sir. This is all from our own pathology, which is in RIO itself. So the patients were sent to the pathology lab of RIO and the blood samples were drawn there and calculated there itself.
Okay, thank you.
Yes, sir.
Dr. Banka, do you think, why did you take up this study? Do you think that branch retinal vein occlusion has got an infective etiology or inflammatory etiology?
No, sir, it's not for, it's not because I think it has an infective etiology. It's simply because of the fact, sir, it is such a common condition that we come across in our outdoor and our retina clinics. And if we have, these are very simple parameters which can be calculated simply from a complete hemogram or a lipid profile. So if we get the patients who are at risk, if we get these parameters tested in them, we can predict these and we can counsel the patients for this much earlier. It is basically an developing an etiopathological basis. Here we are not going to be able to treat the condition better. We are just trying to prevent it, or we are trying to just predict it from happening much earlier. That's about it, sir. And also proving the role of anti-inflammatory, sir, in the treatment.
Okay, thank you very much.
Thank you, Dr. Megha. I would like to call upon the next speaker, Dr.
Thank you.
Madhurima Kumar. Please, can you hear me, Dr. Madhurima?
No. No.
Hello.
Hello,
Dr.
am I audible?
Yes, you're audible.
Okay.
Share your slides.
Is my slide showing?
Not yet. You have started screen sharing? Yes, we can see it. You may start.
Okay. Very good evening to all my seniors and my colleagues. Thank you, Kao, for this wonderful opportunity. I, Dr. Madhurima Kumar, will present a study on comparison of various methods of treatment in orbital venolymphatic malformation, orbital venolymphatic malformations. So introduction, orbital venolymphatic malformations, previously referred to as lymphangiomas, are uncommon benign cystic type 1 vascular malformations. They are multicystic localized malformations that involve the lymphatic and vascular systems, most commonly occurring in the head and neck regions of patients. Several methods have been used to treat orbital lymphangioma, including systemic corticosteroids, injection of a sclerosant, and surgical excision, but currently there are no definitive curative treatments. Sclerotherapy has primarily been used in ophthalmology for the treatment of AV malformation and lymphatic abnormalities like lymphangiomas. Sclerosants are chemical compounds which cause endothelial injury leading to inflammation and vascular thrombosis. Various sclerosing agents can be used such as bleomycin, doxycycline, ethanol, OK432, and sodium tetradecyl sulfate. Now, the aims of our study was to compare the outcome of various modalities of treatment of venolymphatic malformations on the basis of size of lesion and changes in visual acuity, if any. Materials and methods. A prospective interventional institution-based study was conducted from 1st October 2020 to 28th February 2022, for which clearance has been taken from the Institutional Ethical Committee. Data was collected from all the patients who presented to the oculoplasty clinic and OT register of our institution. Informed consent was taken from all the patients and guardians of underage patients. Inclusion criteria were all the patients with orbital and ocular lesions diagnosed radiologically, that is lymphangioma. Exclusion criteria included the patients with hemangioma and those who did not give consent for the study. Anterior segment and posterior segment examination of the patients was done, followed by radiological investigation like contrast CT scan or MRI. The patients were treated with either sclerosing agent, surgical debulking, or oral steroids. Sodium tetradecyl sulfate, Cetrol, in 0.6 to 2 ml doses was the sclerosing agent used depending upon size of lesion. Surgical intervention was performed in 2 cases where the lesion was found to cause compressive optic neuropathy after taking proper consent. Data was collected on the basis of outcome at 3 months after initiation of therapy. Now, the procedure of injection. Sodium tetradecyl sulfate comes in liquid form in vials of 2 ml, 30 mg per vial was drawn in a sterile manner. The site of injection was sterilized and anesthetized using lidocaine 2% jelly locally. 0.1 ml was injected as test dose and any allergic reaction was noted for 15 minutes. If no adverse effect was noted, the rest of the drug was injected into multiple sites at the dose of 0.2 ml per site. Ice pack was applied for 15 minutes followed by a pressure bandage which was kept for 48 hours. The patient was followed up post-op and then for 2 weeks after injection, and it was repeated at 3 weeks interval if necessary for 2 doses. Now, the basis of our treatment was the classification of OVLM, that is the anatomic classification, superficial conjunctiva and eyelid, deep post-septal orbit, and combined lesions. There is an International Orbit Society classification which classifies it as no-flow malformations, that is orbital lymphangiomas, venous flow malformations, which are orbital varices, and arterial flow malformations, which are arteriovenous malformations. Now, coming to results. Male preponderance was found to be 40%, while females had a preponderance of 60% cases. And coming to disease distribution according to age, most of the patients were in the pediatric age group, that is, they presented in pediatric age group in 0 to 15 years, 8 cases, 16 to 30 years, 3 cases, and 4 cases were in the 31 to 45 years age group. These are pictures showing the various sites and the manifestations of the orbital lymphangioma. Now, coming to anatomic classification, we had superficial lesions in 40% cases, deep lesions in 20% cases, and combined lesions that in 40% cases. These are corresponding MRI and CT scans where you can see that this is a deep lesion, this is a superficial lesion, and these are combined lesions, superficial as well as deep. Now, coming to percentage of type of treatment, 54% of the cases were treated with injection STS, that is sodium tetradecyl sulfate. 33% cases were treated with oral prednisolone, and 13% cases were treated by surgical debulking or biotectomy. And this is the picture of the fluid which has been extracted from the lesion. Now, complication after injection STS, pain was found in 40% patients and skin necrosis was found in 60% of these patients. Now, coming to response, the response was stated as good when there was a more than 60% decrease in size and resolving of symptoms. Moderate response was 50 to 60% decrease in size, and poor response was categorized as less than 50% decrease in size. Injection STS showed good response in 5 cases, and 3 cases had moderate response. Oral prednisolone had good response in all 5 cases, and surgical intervention was performed in 2 cases, where it had good response. Now, coming to visual acuity, The visual acuity was found to be normal initially in 67% cases, and of the 33% cases, the visual acuity was hampered at presentation. 27% showed improvement after treatment, and 6% showed no improvement even after treatment. Coming to outcomes, this is an initial presentation, and this is the result after injection STS. These are patients, how they presented initially and after treatment with prednisolone. This is their result. And this is the patient who was treated with surgical debulking, and this is the picture 1 week post-surgery. Coming to discussion, orbital venolymphatic malformation was found to be more prevalent in females, 60%, and the mean age of presentation was 14.3 years. Sclerotherapy showed moderate response in 57% cases as opposed to complete resolution in 51% cases. In the study performed by Farnoosh et al., injection STS had better response in macrocystic lymphangioma than microcystic or combined lesions also seen in the study by Barnacle et al. Found to conclusion, good response was seen in deep-seated lesion, that is surgical debulking. Good response was found in both superficial and combined lesions in oral prednisolone, and injection STS showed sclerotherapy was safe and effective with repeated doses. Now, since the study was conducted with few patients, it is not possible to decisively conclude the best modality of treatment for orbital venolymphatic malformation. Sclerotherapy has found to be a relatively safe mode of treatment for large lesions, while oral steroids are excellent for both superficial and combined lesions. Surgical intervention should be performed in cases where vision is hampered. These are my main references. I acknowledge my mentor and guide, Dr. Chandra Chakrabarti, for this study, and Professor Dr. Ashim Kumar Ghosh, the Director RIU, for allowing me institutional.
Thank you, Dr. Madhurima. That was a lovely presentation. Kindly on your video for the question round.
Is it possible to combine therapies like sclerosing injection with systemic steroid in patients who have got a lesion which is both anteriorly placed and deeply placed?
Yes, sir, it is definitely possible, but since it would hamper the outcome of the study, we have not tried it so far. Actually, in lesions which were deep, we had not tried surgery until recently. We were only treating them systemically. It is only recently that we have started trying surgical debulking for pediatric age groups. We usually give oral prednisolone for combined lesion, and then when we see that the response is not adequate, now we have moved to surgical debulking. Because the sclerosing agent cannot be given in deep lesions without USG guided or eco guided something. Some radiological investigation is necessary.
So what is the cutoff for the pediatric? Means can you inject sclerosing agent in very small children, or you wait for the lesion?
We wait for at least 1 year, because it may resolve in a year. Like one of the patients which we showed, that patient have resolved after 9 months of treatment. So the patient presented at 3 months of age. So we waited for 1 year and the patient was treated continuously with oral prednisolone with systemic monitoring.
But if the patient has got a threat for the vision, like development of
myopia
or optic nerve,
so we perform EUA in those cases, that is examination under anesthesia. And if weighing the pros and cons, if we can get consent for surgery, then we should move forward with surgical procedures.
Thank you, Dr. Madhurima. I would like to call upon the next presenter, Dr. Sumit Dhara. Can you hear me? Dr. Sumit?
Yes.
Please start.
Hello, everyone. My name is Dr. Sumit Dhara. I will be presenting a study of case series of intraorbital metallic foreign bodies presenting to a tertiary care center. Intraorbital metallic foreign bodies are very rare case of 6% of ocular trauma, commonly seen in young males, and usually is a result of high velocity trauma penetrating injuries such as gunshot injuries or industrial accident. It creates a risk of damages to surrounding structures such as the extraocular muscles and cranial nerves 2 to 6. Recent removal of intraorbital foreign bodies is based on risk versus benefit. Early diagnosis and treatment of IOFB is important. The aim of the study is to determine the extent of damage due to intraocular foreign body logging in eye and subsequent management. Retrospective study. This is a retrospective study made in metallic foreign body case. Inclusion criteria of foreign bodies which lodge inside the orbit or cause ocular damages. Exclusion criteria of foreign bodies which are locally superficially. Medical records of 7 patients was included in the study in a 1-year period starting from June 2020 to June 2021 at our institution. Orbital imaging was performed. CT scan is used for injuries with metallic foreign body. Surgical approach of foreign body removal was dependent on location of foreign bodies in orbit. These are the results of 7 cases. The 2 rifle case type of injuries which causes eye block penetration and cause permanent blindness, 2 shotgun penetrations which loss in periorbital cracks and medial cancers which could be removed after conservative and exploration treatment. And non-metallic fragments like fishnets and industrial nails. Some one of those is lodged in orbital against and cause conservative management, and nothing, no intervention is needed. These are some of the pictures. Figure 1 shows a rapid blood injury causing avulsion of the eye. Figure 2 shows shotgun pellets lodged in orbit. Figure 3 shows a metallic foreign body causing amyothermitis later on. This is a figure 4 showing metallic foreign body in metallic medial cancers, which on follow-up cases for develop retinal detachment. We can show here the detachment. And the figure 5 shows a nerve fragments which is struck and lodged in medial cancers. In the during carpenter work, no problem is no restriction of eye movement, no infection. Just managed conservatively. Metallic foreign bodies can be easily detected with plain radiography or CT scan. MRI is contraindicated. Although most metals are inert, iron, copper, and lead may cause serious complications due to toxicity. Gunshot injuries usually lead to severe ocular perforation and permanent blindness. Most patients require removal of the eye after primary repair. Recent studies have reported elevated platelet levels in patients with retained platelets compared to matched controls. For gunshot injuries in which eyeball remains intact, removal of foreign body is appropriate if it causes ocular mobility such as restrictive myopathy, that is, optic neuropathy. In our present study, removal of a bullet and repair of lateral rectus muscles, lateral orbital wall resulted in improvement in 1%. Post-operative formation of granuloma and other manipulation are also there. Surgical approach for foreign body removal is determined based on size and location of foreign body in the orbit. Present study supports that most important foreign bodies can be removed safely with minimal complication. This is the protocol for management of intraorbital foreign body as recommended by AAO. We should assess the injuries, orbital ocular injuries. Imaging studies, CT scan, MRI, do an antibiotic coverage. If it's an organic foreign body, we should always consider surgical removal due to fear of infection and other complications. This inorganic foreign body, we'll first discuss the location. It is anteriorly located and no orbital complication. Then we will maybe remove or may not be removed after discussing the location. If it is posteriorly located, no complication. Will not be removing this. If it's inorganic, like metallic, causing no complications in our eye functions, anything, we should always try to remove it. Conclusion: most of the time it is inert, so rarely it causes infection in eye or orbit. If a trauma resulted in open glove injury, the chance of endophthalmitis increases. Lead from bullet wound may cause lead toxicity. If it's not penetrating globe or causing any toxicity, it is actually safer to test lead in this place. These are my references. I'm acknowledging my mentor for guiding me, mostly for valuable insight, and for talking for allowing me to use institutional data. Thank you.
Thank you, Dr. Sumit. Please on your video for the question round.
Yes, okay. Am I visible? Hello. Hello. Am I audible and visible?
Yes, you are visible. Judges.
How do you actually judge the risk-benefit ratio that a foreign body which has been impacted inside the eye, somewhere in the vital tissues like retina and choroid, that that what will be the benefit and how much risk is there in the outcome? How do you judge that?
Sir, we will judge based on complication. If the metallic foreign body is penetrating the globe, then it will always lead to complication causing endophthalmitis or in one case the retinal detachment, as I have shown. So, if it's not penetrating the globe, it is sitting there in a or no complication, like no restriction of eye movement, no restriction of vision, we just leave it there. In one of the cases, the metallic foreign body, metallic nail is impacted in the medial canthus, and it's impacted in such a way that the patient didn't even feel any comment. His vision was fine, 6/6. His eye movements are totally fine. You can see, however, he didn't even have pain. So we just left it with him. If there's chances increase like painless, restriction in eye movement, we should consider removing the foreign body. That's
if it's inside the eye, I'm talking about some foreign body inside the eye.
Inside the globe, sir.
Inside the globe.
Inside the globe, if it's inside the globe, we should always consider if there is a chance of uveitic inflammation or inflammatory injury. It is it's penetrated into the eye. We should try to remove it. If it is organic, it will cause endophthalmitis. Or if it is inorganic, it might cause retinal detachment. It might cause uveitic. So if it is penetrated inside and went inside the eye, we should remove the foreign body by doing PVV and eye foreign body removal surgery.
How long does it take for the siderosis to take place to start occurring? If there's an intraocular foreign body, how long will it be retained there if left untouched without causing any problem?
So it depends on the in most of the recent studies that I have read, most of the cases after 1 to 2 years of follow-up, the siderosis has not yet developed. So the
so can you leave the foreign body till that time or not?
Yes, if
observe it till that time.
We should check the blood iron level in time, blood protein level, blood iron level in time to time, is to see if increasement or the cirrhosis causing any particular problems in other systemic functions like kidney or liver functions.
So that means the iron has come out from its this particle. It has gone to the blood supply. It has gone to kidney, and then you'll detect it and start.
If we start getting the systemic malfunction, we should remove it at prompt.
Okay. Any other question? I think other judges.
Any more questions, judges?
No, sorry.
Next presenter, Dr. Oishik Sarkar. Can you hear me, Dr. Oishik? Dr. Oishik, can you hear me? Okay. And I would like to call upon Dr. Paridhi. Dr. Paridhi, can you hear me?
Hi, can you hear me?
Yes, yes. Please start sharing your slides.
Yeah. So is this visible?
Yes, it is visible. You may start speaking.
Good evening. I am Dr. Paridhi, here to present a matter of mass and space, a visually significant primary iris epithelial cyst. So iris cysts are something which were first described in 1830 by Mackenzie in a case of trauma with implantation cyst. And since then, they have been so rare that there hasn't been a whole incidence study of primary cysts, while secondary cysts we know can arise from trauma-related implantation or use of drugs such as pilocarpine and other miotics. So primary cysts, which is a classification by Shields, is thought to be of neuroepithelial origin, and this could be epithelial or stromal, and epithelial is seen mostly in adults. So why do we need to know? Because these are mostly asymptomatic, especially the epithelial cysts, which do not grow progressively large until they are symptomatic. When they obstruct the visual axis, can cause corneal decompensation, uveitis, or secondary glaucomas. So in this case, we had a 59-year-old man presenting to our OPD with diminution of vision in his right eye since 5 months. And he noticed himself a dark mass occluding the center of his eye. On slit lamp examination, we saw a dome-shaped brown mass arising posteriorly in the posterior chamber. We performed a gonioscopy which showed peripheral anterior synechiae inferiorly and narrow angles in the inferotemporal quadrant. After pupillary dilatation, the whole surface was seen to be smooth, arising from the posterior surface of the iris. We proceeded with the differential diagnosis of a ciliary body melanoma and advised the gold standard ultrabiomicroscopy. In this, we saw that a clear, smooth, hypoechoic cyst was seen in the inferior temporal segment from the posterior surface of the iris. There was no involvement of the ciliary sulcus, ciliary body, or the nasal quadrants. So here we explored the option of a surgical excision, since it was large enough to block the visual axis, as well as a laser ablation would have caused intense reaction, which we feared. And so the whole body was excised in total. This also had the advantage of obtaining a specimen for HPE, which is histopathological examination. So this is a photo of the patient preoperatively, which shows a large inferotemporal cyst in the dilated form, in the dilated pupil. And this is the image post-operatively, where we also performed phaco, since the ultrabiomicroscopy had shown that the cyst is adhered to the capsule, so we feared development of cataract later. Post-operatively, we were very glad to see that the anterior chamber was clear, no inflammation was seen, and the histopathology showed pigment epithelial components. Pigment epithelial components in an iris cyst, in a primary epithelial cyst, can happen in central or mid-zonal cysts, whereas if the cyst extends from the ciliary body or the ciliary sulcus, they will also have the non-pigmented ciliary epithelial components. So this was a mid-zonal epithelial cyst, which is commonly seen in age groups 60 and above. So after 6 months of meticulous follow-up, there has been no recurrence. However, it does incur the question, what should we do if there is a recurrence? We plan to follow up the patient to note for any recurrence or occurrence of new cysts in either eye. And since we are closely following the patient, we do not expect the lesion to grow enough to obstruct the visual axis again. And so we do think we should consider a Nd:YAG or argon laser ablation for the cyst if it arises. So the take-home message is that iris cysts are so rare that we do not even see a second patient in 3 years of my post-graduation in this institute. And so it is important to discuss the different modalities of treatment that we can do. First of all, pigment epithelial cysts do not grow very large normally, so observation should be the first line of treatment for pigment epithelial cysts. Then we should go for non-invasive procedures and non-surgical procedures such as laser ablation. Another technique would be a fine needle aspiration of the contents with sclerosant injection in the form of alcohol or sclerosing agents. Surgery is performed if a large cyst is seen or if we have to remove the cyst in case of a detached floating cyst. And so in this case, where we explored the surgical outcome, we saw that the functional outcome is not poor. There was no reaction and there was no complications seen post-operative. Thank you.
Thank you, Dr. Paridhi. That was a very lovely presentation. Judges, please.
What would have happened if you just have made a YAG laser opening into the cyst? Because anyway, you can't really excise it fully.
Yes,
Part
sir.
of the cyst is already retained within the atrophy.
So that is why we are closely following up for any recurrence. So there are two complications that we expected with laser. The first was with the expulsion of the fluid, which was in the cyst. We were expecting inflammation that could have led to further pus formation and a secondary glaucoma. And the second was, since the cyst wall would be retained, if there was a blockage of the opening, there would be a recurrence much faster than with a surgical option. And with the surgery, since we have removed most of the epithelium, the cyst has collapsed, and unless it again joins, because the pigment epithelial is not continuous anymore, so unless it becomes a continuous membrane, it cannot inflate to form a cyst, which will cause symptoms again.
Had the cyst being in the pupillary margin, or it has developed from the pupillary margin, will the line of management change, or it will be the same of excision? And
so with multiple cysts, we can try laser ablation. With the single cyst, we can also try a sectoral iridectomy, which will include the whole cyst base as well. Surgery is definitely not the first line of treatment that we would have preferred, but this was a very large mid-zonal cyst, which we thought would respond well to surgery. So it is based on case selection for every patient.
Was it easy to identify the site of origin of the cyst?
So it was not. So we had to rely on the ultrabiomicroscopy. Unless we dilate the patient, we cannot exactly tell if it is only a pupillary or a mid-zonal cyst, because these two will not have any transillumination. If it is a ciliary body, iridociliary sulcus cyst, it will also show transillumination. So at least we could rule out that it is not originating from the ciliary body.
Okay, thank you very much.
Thank you, Dr. Paridhi. I would like to call upon the next presenter, Dr. Shapna Biswas. Dr. Shapna, can you hear me?
Yes, ma'am.
Yes, we can hear you. Please share your slides.
Is my screen visible?
Not yet. Hold on.
Present.
The slides are not visible, Dr. Shapna.
Just a minute. Is it visible?
We can see your screen, please. Slide share.
Is it visible?
No, we cannot see your, we can see your Zoom screen. We cannot see your slide share. Yes, we can see your slide share. Please continue.
Yes, ma'am. Good evening, everyone. Today, my presentation about incidence of narrow angle in people attending ophthalmology outpatient department in a tertiary care hospital over 18 months. Primary angle closure glaucoma is one of the leading cause of blindness worldwide, affecting about 26% of glaucoma population globally. Primary angle closure suspect is defined as occludable narrow angle or iridotrabecular contact on gonoscopy.
Lights are not moving.
Hello, Dr. Now your slides are not moving. We can just
make it in full screen.
Visible, ma'am?
No, we cannot. You are just stuck on the first screen, basically. We cannot see the next. We cannot see the slideshow. Okay, I'll come back to you later again. Please see your connection. I'm calling upon the remaining.
Visible.
Visible. Moving.
No, it is not moving.
Moving.
I will call upon you later again.
Moving.
Okay. We can
it's moving
see
now.
it. Okay. You may continue.
Primary angle closure glaucoma
Yes.
is one of the leading causes of blindness worldwide, affecting about 26% of glaucoma population globally. Primary angle closure suspect is defined as occludable narrow angle or iridotrabecular contact on gonioscopy. If undetected, 1 in 4 primary angle closure suspect population will develop primary angle closure with elevated intraocular pressure and/or stress synechiae in 5 years. In those who develop disease, permanent optic nerve damage and irreversible blindness may occur. Key in prevention of PSCG relies on timely detection of occludable narrow angles and referral for laser peripheral iridotomy if indicated. Aims and objective of my study was to evaluate the incidence of narrow angle on patient attending the ophthalmology outpatient department and detect narrow angle in earlier stage and can guide patient to prevent development of narrow angle glaucoma and deciding on the safety of mydriasis in routine office examination prior to surgery as cataract extraction or its therapeutic agents such condition as corneal ulcer or uveitis. Materials and methods. Study design was cross-sectional observation type of study. Study period was January 2020 to June 2021. Patient selection, patient attending the ophthalmology outpatient department after satisfying the inclusion criteria. Sample size was 500 eyes. That is 250 patients. Both eyes were examined. Inclusion criteria: the patient were 40 years of age without any symptom of glaucoma. The exclusion criteria: non-glaucoma patient, non-diabetes, hypertension, pre-existing corneal and retinal pathology, significant media opacity, post-trauma, post-surgery patient, inability to provide informed consent. The procedure was subjective refraction, corneal diameter measurement, slit lamp examination, applanation tonometer with Goldman applanation tonometer, fundus examination with 90D, gonioscope with Switzerland gonioscope, measurement of axial length and anterior depth with immersion biometry. This is the clinical photograph showing the torchlight examination, slit lamp examination Van Herrick method. This one is paper studying showing of angles that was followed in my study. Anatomy of normal anterior angles, that is Walvis line, one pigmented trabecular measure, scleral spurt and ciliary body band. This one is open angle and this one is closed angle. The result: distribution of patient according to age. In my study, 51 to 60 years old patient were higher incidence, that was 34%, and female were more prone to incidence of narrow angle. And Shepard's rating of AC angle, open angle was 325 and narrow angle 175, and very narrow angle is 64, that is 12.8%, and moderate narrow angle is 22.2%. Distribution of Shepard rating: anterior chamber angle with Van Herrick, grading of anterior chamber, very narrow angle, moderate narrow angle, open angle and wide open angle. P-value were less than 0.01%, that was significant. And the open angle and narrow angle P-value was less than 0.01%, that was also significant. Distribution of very narrow angle group with different parameters, that is anterior chamber depth, axial length, and refractive status and status were very significant, but corneal diameter was not significant. Logistic regression with age, the P-value was 0.001%. The PSCG is a disease with a different incidence, indeterminate initial stage, and a varied presentation in different diseases. The term angle closure glaucoma evokes diverging image for the different ophthalmologists, and there are many classifications subgroup overlapping each other. Although we did our study among middle age to elderly population, the incidence of narrow angle among the elderly population were high in comparison to the middle age group. Similar increase in the prevalence of glaucoma with advanced age has been reported in several studies. My study was based on the Indian study like Andhra Pradesh Eye Disease Study, Orbital Comprehensive Eye Survey, and Central India Eye and Medical Study found a significant association with age and glaucoma.
Undetected narrow angle increase the risk of incidence of angle closure glaucoma and PSCG, can prevent that angle closure in a significant number of cases, and patient can recover from angle closure without significant visual defect if treated early. Thus, early detection with appropriate counseling in patient with narrow angle is critical for patient overall eye care, and eye care provider must be aware of the risk associated with narrow angles. Conclusion: old age and female have shorter axial length and steeper corneal curvature has association with narrow anterior angle. Corneal diameter and anterior depth are associated with narrow angle. Incidence of narrow angle is higher in hypermetric patient. So routine slit lamp examination with colonoscopy of every patient is very crucial for diagnosis and prevention of glaucoma. This is my reference. Thank you.
Thank you, Dr. Biswas. Kindly on your video for the question round.
Hello. Hello, Dr. Biswas. I just wanted to ask you how you could calculate the anterior chamber depth up to the second point of decimal. I mean, what method did you use to calculate the anterior chamber depth?
So it's first under slit lamp using Van Herrick method, and then the immersion biometry.
With the immersion biometry, you can calculate the anterior chamber depth up to the second point of decimal. Okay.
So I'm first one slit lamp examination Van Herrick method, followed the Van Herrick method.
Van Herrick cannot give you. I mean, it's just an eye estimation. It cannot be calculated up to second point of decimal. And secondly, what are the steps you followed for the gonioscopic evaluation of all the patients? Was it done by a single operator or was it done by different people?
So actually, the patient who came to our OPD for routine examination, without any symptom, we just took the patient and counseling them about the gonioscopy and its outcome. And then under topical anesthesia, under slit lamp, we use the Swissman gonioscopy and do the gonioscopy.
Was the ambient lighting changed? Was the slit lamp beam height changed? Were there different observers who did the gonioscopies at different patients? Okay, thank you.
I would like to call on the previous people who could not connect or were absent. Please respond if you are there. Dr. Arpita Kolar. Dr. Arpita, can you hear me?
Yes, I can hear you. Hello.
Okay, please share your slides. Yeah, we can hear you.
Am I visible?
Not yet. Yes, we can see it. You can continue. You may start it.
Okay. Good evening, everyone. Today I'm going to present a varied presentations of limbal dermoid and their management at a tertiary care hospital. Limbal dermoids rank among one of the most common tumor of the corneal limbus. They are ocular choriostomas composed of fibrous and fatty tissues, most commonly located in the inferior temporal quadrant of limbus, often seen associated with golden hair syndrome. Pathogenesis is generally multifactorial and very rarely more than one family member have been found to be affected. There are three grades of limbal dermoid. First is superficial tumor measuring less than 5 millimeter. Next is larger lesions covering most of the cornea, extending deep to stroma and down to the Descemet's membrane. The last involves the whole cornea and structures of the anterior chamber. Our study included 15 patients with limbal dermoids who presented over a period of 2 years from March 2019 to March 2021. The cases were studied retrospectively. Case records were obtained from oculoplasty and OT register. Institutional ethical committee clearance were obtained, and informed consent was taken from all the patients. Inclusion criteria involved all patients who were diagnosed clinically as limbal dermoid, and we excluded patients having mass other than having any other mass other than limbal mass, and those who did not give consent for the study. These are some of our cases. Case 1 is a 5-year-old male who presented with a mass in the right eye, which was found to be brownish yellow on examination in the nasal quadrant, measuring approximately 3 into 3 millimeters square. The patient was treated with simple excision and amniotic membrane grafting. Next was a 1-year-old male child who presented with a mass in the right eye. It was a brownish white round mass in the inferior temporal quadrant, measuring approximately 3 into 2 millimeters square, and the patient has right-sided microtia. This patient was managed conservatively. The next is a 9-month-old child who presented with a mass in the right eye. On examination, it was found to be a brownish pink mass noted in the nasal quadrant. Size was more than 5 millimeters and associated with preauricular appendage. The patient was treated with excision and penetrating keratoplasty. Next was a 2.5-year-old female with a mass in the right eye, which was pale white in color and noted in the inferior temporal quadrant. The patient was managed conservatively. Next was a 5-year-old male who presented with a mass in the right eye. The mass was brownish yellow in the inferior temporal quadrant, measuring approximately 2 into 2 millimeters square. The patient was managed conservatively. Next is a 1.5-year-old male who presented with a large mass in his right eye. The patient was having a round brownish pink mass, which was noted in the nasal quadrant, measuring approximately 1 into 1 centimeter square in diameter. The patient was treated with penetrating excision and penetrating keratoplasty. The next was a 2-week-old male who presented with a mass in the right eye. It was a brown mass in the inferior temporal quadrant, approximately 7 into 5 millimeters square, associated with upper eyelid coloboma. This patient did not get clearance on pre-anesthetic checkup and was subsequently lost to follow-up. Next, we found a patient with who was 1 year old with a mass in his right eye. The mass was brownish white, measuring approximately 3 into 2 millimeters square, associated with right-sided microtia. The patient was managed conservatively. Next was a 1-year-old male patient who presented with a large mass in the right eye. The round mass was measuring approximately 1 into 1.5 centimeters square, but the patient was lost to follow-up. Limbal dermoids belong to the benign congenital tumors containing choriostomas. They are generally dome-shaped, may have keratinized surface. Hair follicles and cilia could be visible. Management may be conservative with artificial lubricant in epilation of offending hair, and surgical removal can be done in cases of cosmetic disfigurement or when causing visual disturbance. Cosmetic concern still remains the main indication to remove the limbal dermoid, and in order to avoid development of amblyopia, surgery at an early age is preferred. Patch graft may be done in some cases when most thickness of cornea or sclera is removed. An amniotic membrane can be sutured to underlying sclera, or fibrin glue can be used. Limbal cell transplantation has also been found to be effective. Use of 0.02% mitomycin C applied for 2 minutes following excision has shown benefits in preventing pseudopterygium. In conclusion, we can say all patients do not require surgery. Most of the grade 1 limbal dermoids can be treated conservatively. Satisfactory results are also obtained following simple surgical removal and grafting. Post-surgical amblyopia therapy may be needed in some cases. Our limitations include relatively small number of cases, very short follow-up, and not using mitomycin C. These are my references. I'd like to thank my mentor, Dr. Chandana Chakraborty, for her guidance, and Professor Dr. Ashim Kumar Ghosh for allowing me to use institutional data. Thank you.
Hello.
Hello.
Yeah, I have one question. In this
Yes,
patient, any patients have any spine deformity?
No, sir, we did not find any patients with spine deformity, but we found several patients with preauricular appendage or microtia.
So it's not a classical of golden hair.
No, sir.
Just say that all these patients, what actually did you mean by conservative treatment, number one?
The conservative treatment means a use of lubricant, doing cycloplegic refraction and using spectacle correction.
And all these patients are going to have a very bad dryness of the eye because the tear film is going to be very, very unstable because of the elevated surface, and many a times there are eyelashes on the surface. So it's so difficult to treat the dryness of the eye in such cases, number one. And number two is how just by looking at the lesion, you know that how deep are the lesion, and if you're going to do a excision, how do you actually judge that what has to be done? And if it has to be done
case of excision, ultrasound biomicroscopy is needed, sir.
Okay. And even if you're doing it for cosmetic reasons, you'll have to do grafting, because in most of the cases, the opacity is still deep into the stroma, isn't it?
Yes, sir.
So how do you manage cosmetically? By doing a lamellar graft or a local keratoplasty full thickness graft, or how do you do it?
Sir, full thickness graft may be required in some cases, but since most of these cases presented during the COVID pandemic, grafting could not be done for most of the, even when if someone requires it. And in case of patch grafting, there is chances of astigmatism later, high degrees of astigmatism. That is why patch grafting was not recommended.
And does patch graft actually gives cosmetic results?
No, sir.
Okay, thank you very much.
Yeah, Dr. Kunar,
yes,
my question to you is this: that how with conservative treatment, what are the parameters that you would look at while following up these patients?
Sir, visual acuity, if the size of the mass is enlarging and so dryness associated with or offending hair, hair if present, cilia is present over the mass.
Is there are there certain things which would decide for you the frequency of the follow-up?
Sir, I don't know.
Okay, thank you.
Ma'am, unmute yourself.
Brototi, any presenter is left? Brototi?
Yes, ma'am. Ma'am.
Any presenter is left?
Ma'am, Dr. Ishita, ma'am.
Want to please finish that.
2 more presenters are left. Yeah, Dr. Payal, can you hear me?
Yes, ma'am.
Please start sharing your screen. Yes, we can see it. You may start. You may start.
Good evening, everyone. I am Dr. Payal Katua, and I am going to present efficiency of intravitreal ranibizumab in CNP, monthly versus yearly versus TNE protocol. Oral neovascularization is a part of the spectrum of the disease, age-related macular degeneration that causes abnormal growth of blood vessels from the orbital musculature to the neurosensory retina to the blood membrane. PGT is a fundamental thing for the diagnosis and management of the patients of orbital neovascularization. HDOCT is nowadays popularly used for examination of the patient. Clinical CNV appears on OCT as an hyperreflective area in contact with the front of the RT, and the pathology may be dome-shaped
area appear as a thin formation, which is principal for moving the type. Retinal edema always present to some extent in front of the active membrane. PCT is an has been useful tool for monitoring the treatment response of anti-VEGF agent and is reliable to determine the need for retreatment in PAD and PRA protocol. Objective of my study is to compare CMT in the patient of CMV receiving intravitreal ranibizumab following monthly PRA and PAD protocol. After ethical committee clearance, 63 patients were recruited in my study and CMT was measured using HTOCT. And after initial management with a loading dose of 3 intravitreal ranibizumab at monthly interval, patients were followed up for 9 months as per their corresponding protocol. Here is the OCT of one of the monthly protocol patients. You can clearly show there is a significant decrease of macular edema after 9 months of follow-up. The visual acuity of the patient improved from 660 to 69. Now this is the one of the patient undergoing PRN protocol, and the macular edema also resolved after 9 months of follow-up, and the visual acuity improved from 636 to 612. This is a UCT finding of PRN protocol patient, and the visual acuity of this patient improved from 660 to 624. Coming to the result, out of 63 patients, 33 were male and 30 patients were female. And most of the patients was in the age group of 61 to 70, followed by less than 70, less than 60 age group. And the average number of injection was highest in case of monthly protocol, which was 8, followed by PRN and followed by PRA protocol. And average decrease in CMT was also highest in monthly protocol, followed by PRA and followed by PRN protocol. And average improvement in visual acuity in terms of 19 students chart, monthly was showing maximum result, followed by PRN and followed by PRA. And according to the p-value, monthly was statistically significant than both PRN and PRA, and between TNE and PRA, there was no much significant difference in the study. In conclusion, our finding indicate that monthly intravitreal ranibizumab is superior to both PRA and PRA in decreasing CMT and improving visual outcome in the patient of CMV, whereas PRA is more effective than PRA in reducing CMT, but visual outcome was similar. Coming to the other trials of intravitreal ranibizumab, Marina and Anchor trial showed satisfactory result in improving visual acuity in case of monthly protocol. And a trained study showed that PRA and monthly protocol had similar outcome in improving visual acuity. And in the study, there was no significant difference in mean central retinal thickness and visual outcome. These are my references. Thank you.
Thank you, Dr. Pyle. I would like to call upon the judges to start the questions. Dr. Pyle, you may on your video.
Good evening, Dr. Pyle. I just wanted to ask you that all these patients were segregated into the groups. Was the central macular thickness pre-treatment levels comparable in all the cases?
More or less comparable in all the cases. I have compared the decrease in the CMT.
No. Before you started treatment in the 3 groups of these patients, were the central macular thickness comparable in all the cases?
Yes, sir.
Okay. And how did you randomize the patients into these 3 groups?
I have done a randomized control trial.
No, actually, the question is, what is the process of randomization? You use any software for randomization or something like arbitrary?
Arbitrary, sir. As the patient comes, just choose the patient systematically.
Okay.
We may proceed for the next speaker.
Yes. Next this is probably the last presentation. Dr. Ishita Batra, can you hear me?
Yes, ma'am. Yes, ma'am.
Yeah, you may start sharing. Dr. Ishita, we cannot see your slides.
Ma'am, are they visible now? Ma'am, are they visible now?
Not yet. They are not visible.
Ma'am, I'll just check, ma'am. Ma'am, is it visible now?
Yes, you may start.
Ma'am, I'm sorry for the internet connection that went wrong. I'll start it, ma'am. My topic for today is COVID-19 associated dyno-orbital cerebral mucormycosis. We'll start with the introduction. The COVID-19 pandemic gave us use of steroids as a therapeutic agent, which was associated with diabetes and irrational use of antibiotics, which made the land fertile for fungal growth, as evidenced by the recent surge of mucormycosis, which we saw in the year 2021, which entangled the sinuses, the orbits, and the brain. The purpose of my study was to study the epidemiological factors which were specific to COVID-19 associated ROCM, and to find the predictors to find the severity of the orbital involvement. The materials and methods included, it was an observational study conducted in the SAMES Hospital and PG Institute, Indore. In this observational epidemiological study, we included 66 cases of all forms of COVID-19 in the months of May and June in 2021. History regarding COVID-19 illness, including the ICU stay, the oxygen support, the type of mask, the oral hygiene used, and the use of antibiotics, along with the use of steroids and immunomodulator, were taken from the patients. Grading of the disease and the orbital involvement as per the ROCM staging and the Sion Hospital scoring system were done respectively. Chi-square test was done to find the correlation of the inquired factor with the staging, and NOVA-T test were done to find the further correlation with the severity of the orbital involvement. My results were, out of the study population, 90% of people who contracted ROCM were in the post-COVID recovery phase, and with an 85% of male preponderance. We could establish that the staging and the SHSS were directly related to the period of the illness, the history of the ICU stay, the oxygen support,
the type of the mask used, the survival of the patient, and the type of antibiotic and the immunomodulator used. As we can see in the diagram, the orbital, the sinus, and the brain involvement respectively. In the end, if you want to conclude and discuss, we'll say the epidemiology and the risk factors. Our observations revealed the middle-aged people of about 40 to 60 years were male. They belong to the rural population, were middle class, were mostly affected. All the subjects were found to be diabetic at the time of diagnosis. It was noteworthy that the proportion of subjects were diagnosed to have new onset diabetic during or following the course of COVID-19 illness. Whether this is responsible for immune dysregulation, making the subject susceptible for mucormycosis, needs future probing. Major had history which was suggestive of COVID-19 like illness in the recent past. COVID pneumonia was observed in a large majority, although 60% of subjects had a definite history of receiving steroids. It was not confirmed in the 40%. Though majority had history of hospital admission, more than half of them were treated with oxygen, and they were universal in our study group. I would like to conclude by saying the factors which were predisposing to ROCM were the patients who got exposed to during COVID illness were identified. And by treating COVID, this may aid to recover ROCM and hence orbital morbidities and mortalities. Thank you.
Thank you, Dr. Ishita. You may on your video for the question round.
Thank you, Ishita. It was a good presentation, but I wanted to know that what is the shortest period, incubation period for this ROCM and the longest one?
Sir, out of the 66 patients that I saw, there were a lot majority of patients who got, they were in their COVID phase and they got mucormycosis during that phase itself. It could be less than, we could say 7 days, and the maximum, sir, reached up till 21 days. The one patient which I saw, it was maximum up to 21 days. And
so is there any difference in the severity that those who are getting it early and those who are getting it a bit late?
Sir, the latent period, I don't think had much relation.
But who are the patients who got it worse? Means who got a mortality and a very severe form of ROCM?
Sir, I think the latent diabetics were the most affected, not who had diabetic, not who were diabetic in the past, but the latent diabetics who were never aware of the diabetes.
So why was it so? What was the probable reason for those latent diabetic getting it?
Sir, our main treatment in COVID-19 being steroids and immunomodulators caused the rise in sugar more. And
but sugar is monitored in all the patients every day, twice a day, isn't it?
Sir, as the patient.
But why is it more common in latent diabetic as compared to diabetics?
So my answer
What might be the reason?
Are unaware of their status and not on any medication. So that could lead, because they were not on any anti-diabetics, on any OHAs or insulin or any sort of treatment.
You mean to say those who are latent diabetic are more immunocompromised as compared to patients who already have got diabetes and are being treated?
Yes,
you mean to say that?
Could be a reason. Yes, sir, that could be a reason.
Okay, thank you.
Thank you, Dr. Batra. This was the last presentation for today. Is Dr. Oishik available? Is Dr. Oishik there? Okay, I do not think he's there. Thank you everyone for giving me the chance to moderate to such a stimulating discussion. This was it for today.
Hello, Brototi.
Yes, ma'am.
Any more presenters?
No, ma'am. We are done.
Any more presenters are there?
No, ma'am. It is done.
So this is the end of our session. Almost we are coming to close. I will request our judges, respected judges, to please have 1 or 2 words about today's presentation quality, and if they want to give any message to the presenters, please. Any of the judges? 1 or 2 words.
Yeah, nice presentations on the whole, but perhaps for our, the generation, I would suggest that better statistical analysis should be, they should be practicing it right from now.
Okay. What I could see, the presentations were great, the studies were really great, but I've got a few points to bring up. First of all, is there too much of text in the presentations. There should not be more than 5 lines and not more than 5 words in a particular line. If there is too much of text, we get to get more engaged in reading text than to hear what you are saying. Number one. And number two is in the discussion, only the most important salient points should be there. Not so many things written in the discussion part. It has to be a very summarized portion of what you have talked or what you have worked upon. Thank you very much. But otherwise, the presentations were actually great.
Presentations are great, really great. But I have one suggestion to that lady who have presented the iris cyst. A single case, it's better to present as a poster. It's my suggestion. It's a nice case. You can present it as a poster, not as a paper.
Yes, sir. Thank you, sir. Noted.
Yeah. Also, one word suggestion to all the presenters. I think the formatting and design of the slides should be more, up to the internationally accepted standards or guidelines as to white background and high contrast letters. Apart from what Dr. Bose has already said, various designs and various contrasting colors are, we should practice not to design the slides like that.
Another thing is try to finish it within time, within stipulated time, for which rehearsal is required before presenting the papers.
Thank you, judges, for your feedback. Thank you. I request our chairperson, Dr. Amarnath De and Dr. Sanjay Thakur, please 1 or 2 words. Dr. Amarnath De is here. Hello. Dr. Sanjay Thakur is here. If they are not audible, then I think
Dr. Sanjay Thakur is here.
Sanjay Thakur is there. 1 or 2 words.
Yes, I am here.
Yes. Yes.
Hello, I am here.
Yes, please, yes. 1 or 2 words to the.
I would like to congratulate all the PGTs for their academic and I hope they will continue this research aptitude in their future life also. Thank you for making me a part of this seminar. Thank you.
Thank you, Dr. Thakur. I request our secretary to please give the vote of thanks.
Well, it was really enjoyable to see so many young presenters present their research work, and many of the nice cases were really extraordinary. And thanks to all of you for presenting here. Thanks to all the judges for listening to all the presentations individually and so carefully and passing on their valuable comments, which will be useful for our presenters' future. I think you will follow the guidelines, what they suggested you in your future. And thanks to the chairpersons, Dr. Sanjay Thakur and Dr. Amarnath De, for being here and listening to all the presentations. Thank you, Dr. Chandana Chakravarti, because you are the key person to organize this whole session. And I personally would like to see all of you on 3rd April in our physical conference at Taj Vivanta. starting at 9 o'clock. Breakfast will be on from 8 to 9. So please, all of you, whoever can come, whoever is attending here physically, please do come there also. That's it. So,
almost okay.
All of you, once again.
Thank you. Thank you, Shurati. So, good night. Good night.
Thank you, everyone. We can exit our sessions. Thank you, everyone.
Yes.